guys, this week's topic in pharmacology is respiratory emergency pharmacology. I'm recording from my home, so this is my welcome to my home studio slash kids play area slash a little bit of everything else. So you have to bear with me if there are distractions, which is absolutely possible and probable, but we will get through it. Hope everything is going well so far. I'm going to post another video in a little while in response to your first week's attendance verification check-ins, just to address a few things that I had seen. So let's get started real quick. So we are looking to begin with at the North Carolina State Protocol AR4. AR4, and this is linked in your Blackboard under this week's material, and this is the adult COPD / respiratory distress. So just a quick note, obviously there are more types of respiratory distress than just COPD and asthma. However, in the pre-hospital setting, typically we're treating one of two things. We're treating either bronchial constriction or we're treating pulmonary edema. Pulmonary edema is primarily a cardiogenic problem which results in respiratory issues, and so we treat it a little bit differently than what we do bronchial constriction. So today's topic is focusing primarily on bronchial constriction, so we're going to look at the management of that. I'm also still getting through a little bit of allergies, so I apologize. Alright, so some things to think about. If I can make my computer work here, I'm sorry. So history: asthma, COPD, chronic bronchitis, emphysema, congestive heart failure. So congestive heart failure is on here in the COPD protocol. Now that doesn't make a whole lot of sense, obviously, because these are two very different issues. So how could they possibly be related? And why is a history of congestive heart failure in the adult COPD / asthma respiratory distress protocol? The reason for that is because we have to think about differential diagnoses to begin with, and that's over here on the right hand side of the screen. We'll look at that more in just a minute. But additionally, it's important to know that COPD is a potential cause of CHF, and we will talk more about that in a couple of weeks when we talk about congestive heart failure. Oftentimes these patients are on home oxygen. COPD patients, remember, they have trouble getting air out, not necessarily getting air in, because it's a bronchospastic issue. They have atelectasis, the alveoli don't let the air out. They stay hyperinflated. That's why patients with COPD tend to have this big, huge barrel chest syndrome that we talk about, clubbing of the fingers from chronic hypoxia, so on and so forth. But oftentimes these patients are on home oxygen. They wear an oxygen cannula with 45 miles of oxygen tubing throughout their home. They have either a room air concentrator or a great big oxygen tank, something to think about. Oftentimes these patients' SpO2 is lower than what we would consider normal on a regular basis, because remember, with COPD patients, they don't breathe based on the hypercarbic drive, they breathe based on the hypoxic drive. So instead of breathing when the CO2 levels get a little elevated in the CSF, they breathe based on lower oxygen levels. Excuse me. Oftentimes these patients use home nebulizers as well, albuterol, Atrovent, maybe even levalbuterol. We'll talk about that here in just a few minutes. And oftentimes they're on inhaled powdered corticosteroids like the Advair disc. Patients who don't have a chronic history of respiratory issues, maybe their issue is toxic exposure, smoke inhalation, something environmental they've been exposed to. So signs and symptoms: COPD, asthma, shortness of breath, obviously, pursed lip breathing. Pursed lip breathing is more specific to COPD than it is anything else, but that indicates bronchial constriction, because again, these patients have trouble getting air out, not necessarily getting air in, and so they create their own back pressure. It's called PEEP, positive end expiratory pressure, and they breathe like this. And that's very common to see in severe COPD patients. Decreased ability to speak, so we call this 2 to 3 or 1 to 2 word dyspnea, depending on how severe it is. This means that when you say, "Hey sir, my name's Chris, what's going on today?" I can't breathe. I can't. So 2 to 3 word dyspnea. They're not able to make complete sentences because of their shortness in breath. Obviously, these patients may be tachypnic. They're probably going to be tachycardic because they're compensating. They're working hard. Their body's having to compensate for the problems that they're having. Wheezing, rhonchi. Why is rhonchi associated with this? Well, rhonchi is associated with this because, again, this is bronchial constriction we're talking about. Bronchial constriction and rhonchi often go hand in hand in patients with pneumonia. So your patient doesn't have a significant history of asthma or COPD or anything like that to have respiratory distress, to suffer from bronchial constriction. I've got some bronchial constriction right now because I'm getting over a sinus infection. Use of accessory muscles, that one's pretty obvious. We're looking for intercostal retractions, subclavian retractions, just a generalized increased work of breathing. Fever, cough, now that's a good differential diagnosis tool there between, say, the COPDer and the pneumonia patient. COPDers, asthma patients, they don't typically have fever. They may have a cough, but they don't typically have a fever. Fever normally indicates some type of infection, though fever does not have to be present when an infection is there. And oftentimes these patients are tachycardic. We've already talked about that a little bit, but just know too that when the patient does have a fever, oftentimes they are tachycardic. It's estimated about 10 beats per minute for every 1 degree temperature increase. So differential diagnosis, asthma, anaphylaxis, aspiration, you can read the list here. There's a lot of different things that may be going on, so don't just go to the respiratory patient and say, you know what, it's either COPD or it's CHF and there's not an in-between, because there's a whole lot of different in-betweens, and that's what's listed over here. And we'll break some of these down, but not every one of them today. So what are we going to do for these patients? Sorry, I'm trying to figure out how to work this screen recorder. There we go. All right. All right, so we have two different presentations on this particular protocol. We have wheezing and we have stridor. Remember that wheezing is a lower airway obstruction and stridor is an upper airway obstruction. Wheezing can be heard on inspiration or expiration, though it is more commonly heard on expiration. Stridor can be heard on inspiration or expiration, but is most commonly heard on inspiration. All right, so wheezing, let's start here. We're on a lower airway obstruction. First line drug, first of all, it's not even on here, is oxygen. Anybody who has an increased work of breathing should get oxygen. There's no patient that you're going to hurt with oxygen per se. COPDers who are on high flow oxygen for a real long period of time, you could risk quote unquote knocking out their hypoxic drive, but that's not normally something we have to worry too much about in the pre-hospital setting. Excuse me. So albuterol nebulizer, 2.5 to 5 milligrams. Let's go to our drug card real quick for respiratory drugs and look at our albuterol nebulizer. I can figure out how to zoom in here. There we go. All right. So albuterol is going to be the generic name. Proventil or Ventolin are the two trade names, and albuterol's been around for a long time. It's a sympathomimetic. What does that mean? That means that it simulates the effects of the sympathetic nervous system. That medic at the end means it simulates. Remember that lytic goes against. So if it was a sympatholytic, it would go against the effects of the sympathetic nervous system, but since it is a sympathomimetic, it mimics the effects of the sympathetic nervous system. It is bronchodilator and it's a beta agonist. Specifically, it's a selective beta 2 adrenergic agonist. So what does that mean? That means that the primary effect of albuterol is on beta 2 receptors. Does that mean that it doesn't stimulate beta 1 receptors and maybe even some alpha 1 receptors? No, it doesn't. That just means that its primary response is on beta 2 receptors. And that's a good thing, because remember that the primary beta 2 response we're looking for is bronchial dilation. The bronchiole and the alveoli, but the bronchiole and the mainstem bronchus are both lined with beta 2 receptors. So when we stimulate those beta 2 receptors, it causes smooth muscle relaxation, which results in bronchial dilation, which is what these patients are needing. So it relaxes smooth muscles of the bronchial tree and peripheral vasculature, resulting in bronchial dilation. Onset, kind of subjective, and remember that even with our 2.5 to 5 milligrams, which we'll look at more in just a minute, that doesn't necessarily mean that my patient gets that 2.5 or 5 milligrams. And what I mean by that is when we are using albuterol or any type of nebulized medication, the amount of medicine they actually get is very dependent upon how deep they're breathing, how quickly they're breathing, and their ability to suck this down into their lungs. If they're breathing really shallow and really fast, then a lot of this medication is going to stay in the anatomical dead space, and so it's not going to be super effective. So it's real important when you're using a nebulizer to coach your patient's breathing and make sure they know they need to try to inhale really deeply. We want to suck this down. We want to get it down as deep as we can so that we have the maximum effect. All right, so we're using albuterol for bronchial constriction. We scroll down, we'll see side effects: palpitations, dizziness, arrhythmias, chest pain, anxiety, tachycardia, nausea, restlessness, headache, diaphoresis. There's a big long list there. Know that the side effects of albuterol don't necessarily mean that you can't use albuterol in a patient who already has a fast heart rate, or who may already be a little dizzy, or who is already anxious. You've got to weigh the pros over the cons. A common misconception is that if your patient is tachycardic, that you can't use albuterol because it's going to make the problem worse. Albuterol will increase the heart rate, but just saying the patient is tachycardic, so therefore I can't use albuterol, is not a okay thing to think. And the reason for that is because why are they tachycardic? You've got to think about the whys, right? The whys are always more important than the whats. I've said that 100 times. So they're probably tachycardic because they can't breathe. They're working really hard. They have an increased respiratory effort. So we've got to think about the whys. If their heart rate's 180 and it's a narrow, complex, regular, with no discernible P waves, then maybe the reason they can't breathe is because they're in SVT. So obviously that would be a patient that I would approach a little bit differently, and I may not want to give albuterol to that patient. We do have other options for patients who are extraordinarily tachycardic. We'll look at that here in just a few minutes. So your adult dose is 2.5 to 5 milligrams. That's 1 to 2 of the little squirty packs in 3 to 6 mLs. They come 2.5 in 3 mLs, so if you give 2.5 milligrams, then it's 3 mLs. If you give 5 milligrams, it's 6 mLs. You can give up to 5 at the same time. And one thing that's different, well, two big things that are different between you as an EMT and you now as a paramedic, is that first, we don't have to have a prescription. So no longer do we have to have a prescription for albuterol. If your patient needs a bronchodilator, then we can administer a bronchodilator. Second, there is no maximum dose for your albuterol. As an EMT, you can only give it 3 times. But there is no maximum dose for your albuterol now. We can give it as soon as the nebulizer runs out. If you need to start another one, start another one. It's perfectly fine. It is a category C, pregnancy category, so keep that in mind if your patient is pregnant, okay? This is one of those where if the benefits outweigh the risks, pretty much if your patient can't breathe, then the benefits may outweigh the risks, but take that on a case-by-case basis. All right, so that is albuterol. Let's go back to our protocol real quick. And we'll see that albuterol is also listed on the stridor side. Now that doesn't make a lot of sense either, because we already said that stridor is an upper airway issue. Does albuterol open the upper airways? No, it doesn't. And I say the upper airways like there's more than one. Remember, the upper airway is anything above the what? It's going to be the glottic opening, yeah? So anything in the upper airway, or the larynx, I won't say the glottic opening, I apologize, anything above the larynx is the right answer there. So stridor is obstruction due to swelling in the glottic opening, or due to the tongue, or due to the epiglottis from epiglottitis, or something along those lines. Albuterol is not going to fix that. It's not going to help that in any way. However, often patients who do have stridor also have bronchial constriction. You'll have a laryngotracheobronchitis, aka croup, or something along those lines, where you have more than one part of the respiratory system involved, and so therefore it can be considered in a patient with stridor, but know that it's not going to fix the stridor at all. It's not going to affect that. So you'll see that on the stridor side you also have a nebulizer, or epinephrine nebulizer. We're going to come back to that in just a minute. We're going to focus on lower airway obstruction for a minute. So continuing down, lower airway obstruction. Now at the advanced EMT level and paramedic level, remember paramedic can do any and all of this, then in addition to the albuterol nebulizer, it says plus or minus ipratropium. So that means I can give albuterol with ipratropium, or I can give albuterol on its own. I cannot give ipratropium on its own. And ipratropium is Atrovent. Let's look at ipratropium. If we go back to our drug cards. All right. So ipratropium is also known as ipratropium bromide, and it is Atrovent. Ipratropium is going to be your generic name. Atrovent is your trade name. Now, it is not a per se bronchial dilator. It's not a agonist, a sympathomimetic. Instead, it is an anticholinergic, or we could also say that it's a parasympatholytic, meaning that it goes against the parasympathetic nervous system. So specifically, it is a muscarinic acetylcholine antagonist, and you heard that term with your EMS 160 drugs this week with atropine. These drugs both elicit their effects in a very similar manner, though atropine affects the heart a little more, and ipratropium bromide affects the lungs a little more. So what does Atrovent do? Atropine doesn't directly cause bronchial dilation, but instead it helps to limit what's causing bronchial constriction, very similar to how the atropine doesn't directly increase the heart rate, but it helps to limit what's causing the heart rate to be slow. So the two big things that Atrovent does is it helps to limit what's causing bronchial constriction. It also helps to limit secretions. Secretions